So we got Joanna Gabriel. So Joanna is finishing her ACHD fellowship with us. She's also trained as an adult coronary interventionalist, and she is going to present a fascinating case for you. All right.
There we go. All right, hello everyone. So I'm going to start with a case about a 52-year-old female with detransposition of the great arteries who had a Muster procedure who presented with progressive heart failure symptoms. A little bit about her past medical history. She had a Muster procedure and VSD closure when she was 13 months old, then had a residual VSD and baffle leak, so she had that repaired, so that's a repeat open heart surgery when she was 7 years old. And then had recurrent baffle leak when she was 48. At that time, they did not do open heart surgery. They just actually did it percutaneously with an Amplatzer septal occluder. She did present with recurrent tachyarrhythmia, not uncommon in that population, had AFib and flutter, had 2 prior RF ablations, and then developed complete heart block, ended up with a pacemaker and an ICD. The pacemaker, importantly, was a single ventricular lead pacemaker. The ICD was just because primary prevention because of the higher sudden cardiac death in that patient population as well. Now, shortly thereafter, she did develop severe systemic AV valve regurgitation, had a tricuspid valve ring placed. It was a 28 millimeter Edwards ring. At the same time, she had closure of a restrictive VSD. They removed the Amplatzer and then patched closed the baffle leak, and then did a right atrial maze for her history of AFib and aflutter at the same time. Other pertinent history is that she did have rectal squamous cell carcinoma, had chemotherapy, radiation therapy. She was currently in remission when she presented to us in clinic. Just physical exam, obviously there's a 3 to 4 out of 6 whole systolic murmur at the left sternal border. She did have some edema, had an RV lift, blood pressure was 110/65, nothing elevated, and then pulse was 80. Medication-wise, she was on carvedilol, furosemide, and amiodarone for the atrial arrhythmias. She was tried previously on an ACE, lisinopril, I believe, but she did develop syncope because of hypotension, so that medication was stopped. We did not try and retry her on another ARB or ACE of the same class. This is her EKG. She's A-paced, V-paced at a heart rate of 80. This is her chest X-ray, and I don't know if I have a pointer, but here. Use this. So with DTGA, and Dr. Shah can probably add to that too, you tend to have a narrower pedicle because you have this anterior posterior great arteries. You also have a bit of an egg-shaped or oval-shaped ventricle. And here's her single lead in the subpulmonic LV and a lead that's in the left atrial appendage from her pacemaker and ICD. On her pacemaker interrogation, she did not have any shocks. She had a few very infrequent episodes of ATAF that mode switched on her. This is her transthoracic echo when we saw her in clinic. As you can see, she's got a dilated, severely hypertrophied right ventricle with a mildly to moderately reduced systolic function. This is her subpulmonic left ventricle with preserved systolic function. This is the apical 4-chamber view here. Here's her systemic right ventricle, moderator band right here. You actually get to see the baffle going into the tricuspid valve from the pulmonary venous return here. Here's the mitral valve, subpulmonic LV. And again, the systemic RV function is not severely decreased at this point. This is just showing you the anterior aorta. This, again, showing you that here's the baffle. This is the one coming from the systemic venous return to the subpulmonic LV, and there's no baffle leak. There was also no VSD, no residual VSD on her transthoracic TTE. When we started looking at the tricuspid valve on her transthoracic echo, you start seeing that there was actually a worsening of her tricuspid regurgitation. And there's actually more than one jet here. And when you do go down on the Nyquist, you see that this is comes with an effective regurgitation orifice area of 0.3 with a regurgitation volume of 50 cc's and a vena contracta of 8. All these are numbers pretty much that makes the regurgitation fall in the moderate to severe range. And that was a definite worsening from before. So as far as management, and I'll have the panel kind of chime in on this as well. So obviously with heart failure medical management, the one thing she might not be on is a bit of afterload reduction. But in patients with DTGA, for example, there's been one randomized double-blinded placebo-controlled trial with ARBs, valsartan, with 88 patients with systemic RVs that looked at, I think it was a 3-year follow-up to see if there has been any benefit from the ARB therapy. And in that group, there was actually no improvement in your systemic RV systolic function, no improvement in your exercise capacity, and no improvement in quality of life when they did the questionnaire. The one thing they did note, which was statistically significant, is your RV volumes actually got worse in the placebo group. With that, is there anything else you guys think that this patient should be on or should not be on with as far as medical management? Again, medication was furosemide, amiodarone, and carvedilol.
Well, despite the minimal availability of studies that have addressed the use of our traditional left heart failure medications, I still think you need to appropriately manage them as you would if this were a left ventricle. And I realize it may not be as efficient to do so, but I would think that whether it's an ARB or an ACE inhibitor should be considered regardless, at least for a normal, if not slightly subnormal, mean blood pressure.
Yeah.
Regardless of the calculations by PISA, which, as you know, can be fraught with error given if you have multiple and irregular jets.
Yeah.
Your regurgitant volume is clearly severe tricuspid regurgitation. Your visual estimate of it, if we can't all agree, it's probably severe. I would say at least I'm in the wrong, but it's severe. And my eyeball of that right ventricular ejection fraction is it's actually severely decreased, so that in the absence of being able to manage your best by a combination of appropriate reduction of arrhythmias, appropriate reduction of blood pressure, appropriate reduction of any volume overload, you get into an issue of can you have a biventricular pacing strategy? If not, then you may be on the road towards transplantation. And that would be a real problem with all this hardware.
Yeah, excellent point, which brings me to point number 2, which is BIV pacing. So looking at, again, the data or the evidence that we have, which is not that much with BIV pacing in that population, there was a study actually in, I believe it was in the Congenital Heart Disease Journal in 2015, so fairly recent, where they looked at 44 patients. This is a retrospective study, not a randomized or anything of the sort. They looked at 44 patients who had again, single lead pacing. Not all of them were complete heart block. Again, remember, our patient is complete heart block, so she's pacing all the time. These were a bit of a mixed group, both DTGA, LTGA, some pacing, some not, all the time. And they followed them, they did the retrospective analysis, and they saw that half of these patients developed actually worsening systemic RV dysfunction. Mm-hmm. So of those half, they decided that's about 22 patients. Of those 22, they took 17 and upgraded them to BIV, and only 50% of those patients actually had improvement in their RV function. So it's a 50-50 chance that if we were to upgrade her to BIV, that she would have a benefit from that. Any input on that?
Well, I mean, I agree that it's not, clearly there's nothing 100%, even in people who have standard left heart disease. But if you look at the echocardiogram, the septal motion is clearly abnormal. And if you look at the left ventricular apex, including in particular the apical septum and true apex, it has abnormal wall motion. So it isn't just the RV that's causing the problem, it's dysynchrony or lack of synchronization.
Yeah, absolutely. So yeah.
Question about surgical options here, and specifically the option of banding of the pulmonary artery in patients with systemic right ventricles. The logic behind that and what you think of that as an option.
And Alhia, and this is the switch conversion surgery or just PA banding as a palliative?
Just PA band. Go
Okay.
I think it's a good option because that helps remodel the non-systemic ventricle as well as the which is a subpulmonic ventricle. When you're talking about tricuspid regurgitation in a systemic ventricle, it's a very difficult problem to address because it's the tricuspid valve is not necessarily a systemic valve. It's not meant to be a systemic valve, and this is banding can buy you time. Again, resynchronization therapy is a very good option, and getting the leads as close to the septum as possible really help improve the ventricular function considerably.
And then, Rashma, since I have you here, so for tricuspid valve replacement, for example, when is it that you call and you say this is not going to actually cause any benefit? And as far as, again, papers out there, they just kind of mention two things. One, if you have already severe RV dysfunction, which makes sense, and the other one, if you have elevated subpulmonic LV pressures. They mention a number specifically of 50 millimeter mercury, pretty much elevated pressures of the subpulmonic LV.
When the problem is annular distraction and migration of the papillary attachments or the caudal attachments, clearly this is a right ventricular failure issue, and in that case, tricuspid valve replacement will not benefit. Again, arresting the heart will drop the ejection fractions considerably, and that's something we would like to avoid. So at that point, we would probably determine the risks outweigh the benefits.
Okay, and with her systemic RV in here, I'll show you the echo one more time so you can get a look at that. Would you be comfortable actually doing a tricuspid valve replacement in that patient?
Right here, I mean, the RV is synchronous, it's dilated, the function is down. I'm not sure that the benefits of replacement outweigh the risks here.
Okay, and this is here, again, I'll show you the amount of tricuspid regurgitation. Now, another point as well is that she has 3 prior open heart surgeries, and her STS score is about 21.7%, so fairly elevated for surgery in general. So that brings us to, again, same point, would you ever even consider a switch conversion surgery on a patient that's 40 or 52 years old?
I would say it's extremely high risk, and at this point, we are probably thinking about more traditional routes, such as consideration for transplantation, honestly.
Transplantation, okay. All right. How about the rest of the panel?
Just 1 minute, 1 minute. Lee, talk to us a little bit about that.
Yeah, so we've actually had quite a few patients go on to transplant who've had the mustard procedure. A lot of them have highly sensitized antibodies because of the baffles that they've had. We've also had a fair number of patients who've had much better RV function, but profoundly symptomatic. And what we've found when we actually take them to the cath lab and do an exercise test is that their systemic ventricular end diastolic pressure, at least at rest, is low. And then with a little bit of exercise, we had one patient where it was about, the end diastolic pressure was about 12, and with exercise went up to about 37. She ended up getting transplanted, is doing very well. But these patients are quite a struggle, and I think ultimately a lot of them will end up heading towards transplant.
Okay. And would you, with her presentation, would you consider starting transplant evaluation at this point?
Yeah, I think those conversations early are always better than when you're in dire straits. And then it also gives the transplant committee a lot of opportunities to do a social evaluation and also make sure that the patient is going into the transplant with their eyes wide open. As anybody can imagine, transplant is not an elective procedure. It is an elective procedure, and it's something that we want patients to be fully aware of what they're getting into.
So with this patient, I'll tell you what actually ended up happening. As far as heart failure medical management, there was that concern that she actually had a syncopal episode with ACE and ARB, so that was not re-attempted. With the resynchronization therapy, again, because it's a 50-50 issue, and with the important point that oftentimes if you have severe TR to begin with, even with resynchronization therapy, even if your systemic RV does improve, your TR does not necessarily resolve. So that would still be a problem in her, which might be causing a lot of symptoms. And the fact that she's very high risk for surgery, that making an open heart surgery for tricuspid valve replacement also less feasible and less likely. For switch conversion, a lot of the studies show that, it seems that the surgeons tend to do it when patients are less than 15 years old. And some of the studies have shown, too, that the LV, when you try and retrain it with PA banding, it tends to fibrose more than it does just hypertrophy in younger kids. It just doesn't work when you're that old. And then as far as heart transplant, we felt that her systemic RV function wasn't that bad quite yet. We wanted to see if there was something else that we can do, perhaps as a hybrid procedure or percutaneously, to help with that tricuspid regurgitation.
Yeah, I mean, basically, I may not be up to date on the latest stuff, but from while I was still actively working, of course, some people said I wasn't working, but while I was sitting around watching Jamil work, the information that I saw was once you passed the teenage years, that it was a very high-risk procedure with very little benefit, and even once you got into the teenage years, it was sort of a 50-50 proposition. And I think in this case, you already got an abnormal left ventricle, which may be partly due to the dysynchrony, but it may be partly intrinsic ventricular disease. You've got a terrible left ventricle. You've got a TR that I think if you close off, you may make the right ventricle worse. And it's hard to repair that valve, I think, so it'd have to be a replacement. I'll bet you the RV would get worse. You've got the diastolic dysfunction, which it ain't going to make it better. In other words, the hidden thing here is how do you evaluate RV dysfunction short of catheterization?
Yeah.
So I would be very against the idea of LV retraining. And you're right, the heart transplant's a big issue because of all the operations, but I think it's down to that or you still piddle with the medications.
Okay. Dr. Reardon?
And I think also like going back to the MCS presentation yesterday, that there's been over the last year 3 case series of patients with this exact sort of situation who have gotten mechanical support in situations where they felt like they didn't have maybe as quick of transplant options and things like that. So that would also be a potential option.
That's a good point, mechanical support.
She had cancer in 2013, and she's in remission. How does that affect your transplant and timing?
So I'm not as aware of that specific cancer in terms of the thing, but in general, you have to be in remission for at least 2 years for you to be considered by the transplant committee. It's often done in consultation. It's 5 years for that specific. Yeah, okay.
I mean, that plays a big role with her.
It's 5 years unless it's prostate cancer, and then how many years? This would be rectal, yeah. In pediatrics, we tend to have a little bit more leeway with childhood cancers. You know, we often find that we're willing to transplant pediatric patients as long as they've been in remission for 1 to 2 years. And that, again, is done as a discussion with the whole transplant committee.
Another exception is melanoma, which is mediate size and stage 1, then they can be transplant candidates.
So, I mean, I think this dramatically affects what you decide to do for her, because you've taken her off the category of transplant right now. And I thought there was a CE valve was placed. Was that correct?
She had a valve ring placed.
Valve ring, okay.
Exactly, yeah. Now that Dr. Shannon is here too, I'll just give you a quick, this is a 52 DTGA with severe TR, mildly to moderately reduced systemic RV function. She had complete heart block and had a single ventricle lead pacemaker placed, as well as ICD. And we were just discussing resynchronization therapy in that population. Just wanted to get your opinion on that. As far as improvement, one in the systemic tricuspid regurgitation and the systemic RV function.
So actually, both things can happen. The problem is getting the lead on because it usually requires a thoracotomy. Most atrial switch surgeries leave the coronary sinus draining to the pulmonary venous atrium. Some of them don't, and you can get a CAT scan and find out which flavor it is, but most of them, when we've done these CAT scans, we've wound up finding out that there is not access to the coronary sinus, and therefore we need a thoracotomy to establish biventricular pacing. In the patients we've done that for, most of them have had an improvement. In the chronically paced patients where we've done that, most of them have had an improvement in the tricuspid valve regurgitation. However, the other thing that we have done, not intentionally to do this, but that has worked, is PA banding.
Yeah.
And PA banding, not with the intention of doing a late switch, but with the intention of raising LV pressure, establishing a more neutral ventricular septum, that has at times improved tricuspid valve regurgitation. And I followed 2 patients that are now adults who got PA bands in their teenage years with the intention of making them double switches, and they got, or late arterial switches, and they got so much better that they just have the PA band.
Any other audience questions?
Yeah,
Okay.
if her LV is already abnormal, that's
Yeah.
probably a bad idea, which makes
Okay.
the late switch conversion also a bad
That's a good
idea.
point. Yeah, and her LV is
But
not
Question,
normal. Yeah.
as far as the mechanism of her syncope with ACE inhibitor, I think it's worth trying again a smaller dose and see whether Kevin can reprogram the heart rate, because normally our heart rate going to change, accelerate with ACE inhibitor. I think she doesn't have that. That's why she's having syncope.
Yeah. So
I think
reattempt an ACE
it's a good
inhibitor.
medicine to give it a try.
No. All right. So I'll tell you what actually ended up happening is that we decided to try and tackle the severe tricuspid regurgitation, but via percutaneous, a hybrid percutaneous approach. So initially we just got CTA coronaries, and I'll tell you her coronaries are all normal. She didn't have any anomalous coronaries. This is just a coronal view here. You can tell that the valve ring that was placed, which was at 28, the internal diameter is measuring about 25 now. This is an MPR of the ring here that you can see. Now, again, doing a percutaneous or transcatheter valve placement in a tricuspid valve ring is not a simple procedure, and there's certain things, certain challenges that come with that, including the fact that this is not circular, it's oval. You get perivalvular leaks here, especially that this is also not a complete ring, so you also get the perivalvular leak. You get less of an issue of outflow tract obstruction because you don't have that fibrous continuity with the aorta and the tricuspid valve as you would with a mitral valve, but it's still an issue. And obviously high dislodgement forces, this is the systemic ventricle, so it's a bit more difficult. This is just saying the diameter was 25. So as far as approach to valve, obviously there's several approaches, and we felt that at the end of the day, the transapical would be the most feasible type of valve. The three available at the time were the Melody, Sapien XT, and a Sapien 3, and then valve size, obviously. The axial view kind of is what tells you that where's my little pointer? Oh, there we go. The transapical would be kind of a straightforward shot to actually do that valve replacement. And then these are the type of valves available. You don't need to go into all the details, just to tell you that here's the XT, here's the S3, this here is the XT. S3 has a bit of a skirt, which kind of helps with perivalvular leaks. The one thing is the S3 tends to shorten a lot more when you're deploying it. Both these two valve, the Sapiens, are generally shorter in length than the Melody valve. So again, these are things that are important to know when you're deploying this valve, because you have a target and you don't want to miss that target, which is deploying it right within the ring. Dr. Abul Hosn has already shown a lot of these. This is the tryout in that 3D model of the 30 millimeter PTSX balloon, showing that the Sapien S3 tended to kind of watermelon seed or slide a little bit, making it less likely to use for us. And then this is the video with the XT, and as you can tell, the deployment was right on with that. But again, it doesn't have the skirt that an S3 does have with perivalvular leaks. Just to kind of move on because I'm out of time. Hemodynamics, importantly, the wedge pressure was 20. The LV subpulmonic ventricle systolic pressure was 41. P pressures were not that elevated. This here just to show you the severe tricuspid regurgitation if you look at the opacification of the enlarged atrium here. This is the balloon sizing with that PTSX balloon with a waist of 25. And this is the actual valve deployment here on TEE. And then here, and you can see here's the ring. And here's the valve deployment, and it's right. Perfect deployment right there. Moving on, here's just to make sure that there was no coronary compression and the RCA looked fine. And this is just a comparative here. This is, again, that severe TR. You look at the opacification of the atrium here after valve replacement with that RV gram, and you're not seeing any opacification whatsoever here. This is the post-TEE. You do have a little bit of perivalvular leak, which was somewhat expected, but it's very small and rather hemodynamically insignificant. And you still have the systemic RV at that point was still preserved. And then on follow-up, several months later, this is her systemic RV again. And this is, again, you see that little bit of perivalvular leak here. As far as hemodynamics, right, post-cath, your RVDP did decrease from 18 to 12, and your wedge pressure from 20 to 16. She did very well post-procedure, chest tube was out, and this is actually the first case of transcatheter systemic AV valve replacement hybrid approach transapical with an XT valve. Any other questions? Yeah, so that TTE was several months afterwards, and we'll continue seeing her and monitoring that systemic RV function. Yeah?
Did you set her up for biventricular pacing?
That's a very good point, and I think that's something that if she were to become symptomatic again, or worsening symptoms, or worsening systemic RV dysfunction, I think that's something that we should certainly consider.
Would you have been able to do it at the time that set the leads up at that time? When you did that's why that's.
Yeah, I don't, so we considered that. A great point that you're making about resynchronization therapy, and we certainly considered that. But we were right at the apex of that right ventricle, and I don't think we would have gotten a good enough separation of the two ventricular leads to truly resynchronize. Frankly, if we're going to do that, we were going to need to go back and probably do a full thoracotomy, and we figured we would see how she would do with valve replacement. But I think, a great presentation, Joanna, and I think with these valves, these transcatheter techniques, we're in a new era in many ways, but one way, I think, is that we are no longer needing to put some of these patients through cardiopulmonary bypass, which is something that she may not have tolerated with that relatively poor RV function. Whereas a procedure like this that does not require cardiopulmonary bypass was much more tolerated, and she was out of the hospital within 2 days. As far as the transplantation, we were certainly considering that, but she had had the rectal cancer, I think, 2 years before, so that was not an option. Great job. Thank you, Joanna. I just want to introduce our panel. Sorry, I was remiss not to introduce the panel of experts that we have. We have Dr. Binwali here from cardiac surgery. We have Dr. Child, Dr. Lin, Dr. Reardon, and also Dr. Shannon. And also, obviously taking questions and comments from the audience.